Welcome to Dermatology Discussions. Have you ever encountered one of those uniformly pigmented brown, black, or maybe gray spots, perhaps on a mucosal surface like someone's mouth or even, the genital area, and wondered about the differential diagnoses?
It's a common scenario, definitely.
Well, today we're going to dig into mucosal melanotic lesions. We really want to focus on telling apart the benign ones from those that, need a bit more investigation.
Sounds good. We'll be covering the general mucosal melanotic macules, including those specific genital and oral types.
And also labial melanotic macules, the ones right on the lips.
Exactly. So these mucosal melanotic macules, fundamentally they're benign pigmented patches. Sometimes people call them lentigens, though technically slightly different histologically.
Right. And under the microscope, what's the key feature? Is it more cells or just more pigment?
It's mainly about the pigment. Research shows it's hyperpigmentation, primarily in the basal keratinocytes.
Yeah.
The number of melanocytes might be normal or just slightly increased. But crucially, there are no atypical features, no confluent growth that would make you worry.
So location-wise, we're talking oral cavity lips, gums, palate, the inside of the cheeks.
All common spots.
And also the genitalia. You see them mainly on the vulva, I understand.
Yes, predominantly the vulva in women, but you can also see them on the glands, penis, or perineum, often termed genital melanosis in those cases.
And clinically, they look like these uniform brown, black, or gray patches, maybe getting a bit bigger over time, but slowly.
That's the typical picture. The genital ones are often quite discrete, maybe a bit more deeply pigmented. They result from, local overproduction of pigment, but generally with normal melanocyte numbers.
Is there any known cause or association?
Well, the exact pathogenesis is still a bit unclear. Interestingly, though, research has noted an association, particularly in female genitalia, between these macules and lichen sclerosus.
That is interesting. Why that link occurs isn't fully understood, right?
Not yet, no.
Yeah.
Histologically, for the genital ones, you often see mild acanthosis, that basal layer hyperpigmentation we talked about, maybe a slight increase in melanocytes but no nesting, and sometimes scattered melanophages higher up, what we call melanin incontinence.
Okay. And moving to the mouth, the oral lesions, any specific points there?
Well, one thing noted is that the pigmentation can sometimes be more pronounced at sites of minor trauma.
So irritation might play a role.
It seems possible. The main challenge, though, is distinguishing them from other solitary pigmented things in the mouth: oral nevus, blue nevus, melanocantomas, and, of course, the big concern, oral melanoma.
Right. And how does genital lentiginosis fit in? That needs differentiation, too.
Absolutely. You need to differentiate genital macules or lentiginosis from true lentigens, from melanocytic nevi, especially clinically atypical ones, and critically from melanoma in situ.
Dermoscopy must be helpful here. What kind of patterns do you see?
It can be. Studies describe various patterns: parallel, reticular, structureless, or even globular sometimes.
So quite variable then.
It can be, yes, which adds to the challenge. And importantly, malignant transformation. Have these ever been reported to turn cancerous?
Thankfully, no reported cases of these specific mucosal melanotic macules becoming malignant.
That's reassuring. But management-wise, if it looks benign, do we just leave it?
If histology confirms it's benign, then yes, no treatment is usually needed. However, if a biopsy shows significant melanocytic proliferation, maybe something resembling lentigo maligna, then complete excision is definitely necessary.
And I imagine, given the potential resemblance of the genital ones to early melanoma.
Exactly. Biopsy is performed pretty often for genital lesions, just to be certain. Better safe than sorry, really.
Makes sense. Okay, what about the lips specifically? Labial melanotic macules.
Right, these are quite common. Basically a benign hyperpigmented spot on the lip, similar maybe to a freckle or a simple lentigo on the skin.
And histologically, similar picture.
Very similar. Research describes a linear increase in melanin pigment in the basal layer, with normal or maybe slightly increased numbers of melanocytes, but they're just scattered singly between the keratinocytes. No nests, no atypia.
And clinically, small brown to black spots.
Usually, yes. Typically less than 6 or 7 millimeters. Most common location is the lower lip, especially right in the central third.
And like the other mucosal ones, no reports of them turning malignant.
Correct. Malignant transformation hasn't been reported for these either.
Dermoscopy must be quite useful here, too.
Very much so. It often shows this really uniform brown color with parallel lines, sometimes described as a fingerprint pattern. Seeing that pattern is highly suggestive of a benign labial melanotic macule.
That fingerprint pattern. That's a good visual. So that pattern really helps confirm it's benign.
It really does. It allows for pretty confident reassurance for the patient, which is often the main part of management for these labial lesions.
Just reassurance then? Good.
So wrapping things up, it seems that while both mucosal and labial melanotic macules are typically benign, just spots of extra pigment, essentially, that clinical assessment is crucial. And particularly for the genital lesions, because they can sometimes mimic early melanoma, a biopsy is often warranted to be absolutely sure.
Right. And those histological features and the dermoscopic patterns we discussed are really key tools for getting the diagnosis right and deciding on the best approach.
Definitely. So maybe a final thought for our listeners. Considering the varied dermoscopic patterns we've touched upon, what specific features, perhaps beyond just the standard ABCDEs we use for skin melanoma, would really make you pause and think, okay, this pigmented mucosal lesion needs a biopsy?
That's a great point to ponder. Something beyond just asymmetry or border irregularity in that specific mucosal context. Definitely something to consider in practice.
Indeed. Well, thank you for being with us today.
My pleasure.
And to our listeners, if you like being with us, subscribe for great content like this.